Pleural mesothelioma, a rare and aggressive disease. Surgical treatment would either be a pleurectomy decortication, extended pleurectomy decortication if diaphragm, pericardium, etc. are also removed, or an extrapleural pneumonectomy. Well known fact that extrapleural pneumonectomy is an extremely morbid procedure with a very high fatality rate, discouraged universally across all guidelines and all expert institutions. So now pleurectomy decortication, originally described in 1970s, for the past 5 decades for pleural mesothelioma restricted to one hemithorax, uniform international consensus amongst all the experts and recommendations in all the major guidelines supported surgery. However, the beneficial role of such a morbid procedure, pleurectomy decortication by itself is not a light procedure. Significant air leaks, pleural space infections, intraoperative blood loss ranging up to 10 liters. Such a complex and morbid procedure, is there any need to do it? Is there any benefit such a morbid procedure offers to patients with mesothelioma? The presumed efficacy was always based on case series. So some expert teams operated, the patients did well or decently well. So it was always assumed that surgery is the way to go. In the ASCO guidelines in 2018, patients with early stage disease, it is strongly recommended that surgical cytoreduction should be performed. Evidence quality intermediate. Same ASCO guidelines 2025, January 2025. Does surgery have a role? Surgery should not be offered to all the patients just because it's anatomically resectable. It should only be offered to highly selected patients, T1 to T3 epithelioid tumors. Now, even more dramatic, NCCN January 2024 guidelines, clinical stage 1 to 3A and epithelioid, surgical exploration with either pleurectomy decortication or extrapleural pneumonectomy, followed by adjuvant, or induction followed by surgery, induction chemo followed by surgery. The same NCCN guidelines published, revised in October 2025, just last month. Stage 1 epithelioid preferred is only systemic therapy. Surgical evaluation may be considered. Anything other than stage 1 is T1 and 0. Anything other than stage 1 epithelioid, systemic therapy only. So, what led to these? What evidence accumulated here? The high quality of evidence that accumulated here that changed the ASCO guidelines and the NCCN guidelines significantly is the MARS trial, mesothelioma, MARS 2 specifically, mesothelioma and radical surgery, phase 3 multicenter randomized control trial in the UK, where patients were randomized after 2 cycles of chemotherapy to either undergo an extended pleurectomy decortication, that is surgery followed by further chemotherapy, or chemotherapy alone. So in one arm it is just chemotherapy, and in the other arm it's chemotherapy, surgery, chemotherapy. All 3 types of epithelioid mesothelioma were included, restricted to one hemithorax based on CT assessment alone. 4 established expert mesothelioma centers in UK and one non-expert center in the UK. Surprisingly, the survival was significantly lesser in the patients who underwent chemotherapy and surgery. So, 2 cycles of chemotherapy, surgery, and chemotherapy. This arm experienced a detrimental survival compared to the arm which underwent only systemic therapy. The quality of life was much better. The risk of serious complications were much lower in the arm which underwent chemotherapy alone. Sparked a lot of debate At all points of the trial, the patients in the surgical arm had a 28% higher chance of dying compared to those who underwent chemotherapy alone. Serious adverse events were 3.6 times more common in the surgical arm. So, sparked a lot of debate, a lot of reviewers' comments. We'll discuss this. So, the first comment, critical analysis, was that the inclusion of non epithelioid histologies would have resulted in this negative trial for the role of surgery because sarcomatoid and biphasic mesotheliomas, we know that surgery is not indicated. Surgery should not be done. This evidence, this wisdom had already accumulated over the past 5 decades. So now some critiques pointed out that inclusion of this non-epithelioid histologies is the reason for this negative result. But as we can see, the non-epithelioid and non-epithelioid histologies were actually balanced across the two arms. So it might not have resulted in this negative result. The second critical point was staging was not extensive, FDG PET was not mandatory, invasive mediastinal staging was not done. 4% of the trial population were actually M1 and 8% were actually N2. But the author's justification is that this is a real world scenario. However perfect our staging methods can be, eventually some patients are wrongly staged. And more importantly, the M1 and N2 patients are balanced across both the arms, the surgical arm and the no surgery arm. And even more importantly, when they individually analyzed the patients who underwent PET and who did not undergo PET, the results remained the same. That is, the patients in the non surgical arm, the who did not undergo any surgery, still had a better survival without PET, even with PET. The third important critical comment was that the surgical outcomes were inferior to all available published literature so far. That is, the 30-day mortality and the 90-day mortality were significantly higher in the surgical arm of Mars 2. But the surgical quality control was strictly ensured. The surgeons in the non expert center had to meet minimum stipulated requirements and their surgeries were supervised. And even more importantly, there was absolutely no difference in survival between the expert site and the non expert sites. So, on individual analysis, in expert sites and in the non expert hospitals, in both centers, the non surgical arm had a better survival. Critical point number 4, the patients in surgery arm, only 22% could receive additional therapy, immunotherapy, things like that, which are known to improve survival. Whereas 40% of patients in the chemo only arm could receive these additional therapy. So that might have resulted in the improved survival in the chemo arm. So this is a critical thinking. But the author's reply rather, this should be actually taken as the intent to treat pathway. If you know intent to treat is all patients included first big who began treatment should be included in the analysis because of the to analyze the effect of treatment per se. So the lesser patients in the surgical arm could undergo additional therapy mainly because of surgical morbidity. Just like we say, post Whipple's, few patients only can complete all the adjuvant systemic therapy because of the morbidity caused by Whipple's. So similar to that, it is an outcome of the surgery per se rather than an imbalance between this imbalance between the two groups was not planned. It was a result of the surgery. The patient underwent surgery, could not tolerate further systemic therapy because of the surgical morbidity. So hence, eventually leading to poorer survival. That is an hypothesis, but this per se should not be viewed as an imbalance across the two arms. The Largest published series so far, which included 355 patients. The median survival was 20 months, roughly. And in that, for T1 epithelioid alone, the median survival was a remarkable 70 months. But when Mars 2 authors analyzed only this cohort, the favorable, very early stage T1 to T2 N0 cohort, 80 patients, 82 patients without surgery, 78 patients with surgery, even in this population, the most important slide of this video, even in this population, the patients in the surgical arm fared worse compared to patients who did not undergo surgery at all, calling into serious question the role of surgery in pleural mesothelioma, including the earliest of early stages. That is why, in the NCCN guidelines, even for stage 1 and epithelioid, the T1N0M0, the earliest of early pleural mesothelioma, systemic therapy alone is the preferred option. Surgical evaluation may be considered. Anything upwards of stage 1 and non epithelioid histologies, only systemic therapy. So, to summarize, we need a rigorous pathological assessment by a thoracoscopic multi-quadrant multi-field biopsy to rule out with certainty the presence of any sarcomatoid component. We need rigorous staging to rule out occult M1 and N2 by FDG PET and invasive mediastinal staging. If required, if the imaging findings suggest a contralateral thoracic disease or transdiaphragmatic disease, a very low threshold to perform a contralateral VATS and or a staging lab, and a rigorous fitness evaluation to tolerate such an extensive procedure. After all these things, if we happen to find a patient who is not metastatic, pure epithelioid, early stage, no mediastinal nodes, which is T1N0M0, extremely fit to tolerate the surgery, a pleurectomy decortication plus systemic therapy may be considered in expert institutions who will be able to do the procedure without significant morbidity. Because doing such an extensive procedure causing morbidity and the patient dying because of the surgical procedure per se will counter any benefit, right? The the whole point is to make the patient live, improve his survival. Now, absolutely no role for surgery in obviously distant metastasis, contralateral thoracic disease, transdiaphragmatic disease, transpericardial disease, mediastinal nodes, and non-epithelioid histology. This is very clear, no controversies at all. So, this population, that is the earliest of the early pleural mesothelioma, that is epithelioid, surgery may be considered in expert centers. However, systemic therapy alone is the preferred recommendation as per NCCN. The slightly higher stages, T2, T3, that is disease limited to the hemithorax, but not very low volume. It's a very gray zone. Of course, individual expert institutions will have their own policies, but until further evidence, this is the highest level of evidence that has ever accumulated in management of pleural mesothelioma, and it cannot be disregarded.